In this video, I will share 5 important things we must know about NG tubes and percutaneous gastrostomy tubes before starting our hospital rotation. Let's get started. An NG tube is a flexible tube inserted through the nose down the esophagus and into the stomach, and sometimes down to the jejunum, the so-called NJ tube, nasojejunal tube. A gastrostomy tube, on the other hand, is inserted directly through the abdominal wall into the stomach. The term PICC tube is often used to refer to any type of gastrostomy tube, though it technically describes those placed endoscopically. Percutaneous endoscopic gastrostomy. So from now on, when I say PICC tube, I mean all kinds of gastrostomy tubes. Both deliver nutrition and medications, but the key difference is duration and invasiveness. NG tubes are temporary, typically used for no longer than 4 to 6 weeks, while PICC tubes are meant for long-term feeding, usually more than 4 to 6 weeks, and allow patients greater comfort and mobility. When should we consider NG tube placements in our patients? Think about placing NG tubes in the following situations. First, in patients who cannot safely swallow and need medications and nutrition administration, such as mechanically ventilated patients, severe stroke patients, or any other reason. Or in patients who need nutritional support when they cannot meet their calorie requirements through oral intake. Or in patients who need gastric decompression for bowel obstruction or ileus. Again, NG tube is meant for short-term solution for up to 4 to 6 weeks. If the patient needs enteral support beyond this time frame, it's time to consider transitioning to a PICC tube. PICC tubes are our go-to for long-term feeding, anything beyond 4 to 6 weeks. And this includes patients requiring prolonged mechanical ventilation who need to be transitioned to tracheostomies, patients with prolonged dysphagia from neurological conditions like ALS, advanced dementia, or severe stroke. Also indicated for head and neck cancers, patients requiring radiation therapy when we know they will need supplemental nutrition for more than 4 to 6 weeks. And finally, when patients are heading home and will need continued enteral feeding support. But is it safe to place NG or PICC tubes in every patient? Of course not. But before that, if you would like to receive a summary of this video delivered to your email, kindly subscribe to my Substack page and newsletter. The subscription link is provided in the description field. NG tubes are safe to place in most patients, and the absolute contraindications are limited. The NG tube placement is contraindicated in cases of facial trauma, nasal injuries, abnormal nasal anatomy, or pre-existing sinusitis. An oral gastric tube or OG tube can be alternatively considered in sedated patients, as it's very uncomfortable to place in awake patients. Patients with recent GI bleed, especially peptic ulcer with a visible vessel, are considered a relative contraindication. Gastroenterology should be consulted if NG tube is absolutely necessary here. Now, how about patients with liver cirrhosis? This is a frequently encountered situation. NG tube or OG tube placement is not absolutely contraindicated in cirrhotic patients. But there is, of course, a higher risk of gastrointestinal bleed, particularly in those with esophageal varices, particularly within the first 48 hours of NG tube placement. So enteric tube placement should be considered only after failure of oral supplementations and with close monitoring for any signs of bleeding. PICC tubes, on the other hand, or percutaneous gastrostomy tubes, on the other hand, is strongly contraindicated in cirrhotic patients with ascites due to high complication rate and high mortality rate, actually. PICC tube should be avoided also if there is active peritonitis, bowel ischemia, or mechanical intestinal obstruction. Massive ascites and morbid obesity with a large peniculus are also recognized as major barrier for safe PICC tube placement. How about the tubes themselves? NG tubes come in different sizes measured in French units. Common sizes range from 8 to 18 French. Smaller bore tubes like 8 to 10 French are more comfortable for patients and used primarily for feeding, while larger bore tubes like 14 to 18 French are used for gastric decompression mainly. The tubes have depth marking along their length to help confirm proper positioning on X-ray. One of the most commonly used NG tubes is the Salem sump tubes. These are large bore tubes used mainly for gastric decompression and suction, featuring a double lumen with a blue vent to prevent mucosal damage. Dub-off tube, on the other hand, is a small bore nasogastric feeding tube that is thinner and more flexible than standard nasogastric tubes, typically measuring 8 to 12 French in diameter. The tube features a weighted tungsten tip that helps navigate through the gastrointestinal tract. So for the purpose of nutrition and medication administration, small bore soft tubes are preferred, while large bore, more rigid ones are used mainly for suction and decompression. In higher risk patients such as those cirrhotic patients or recent GI bleeds, small bore soft tubes are preferred and should be gently inserted in such cases. How about PICC tubes? PICC tubes consist of several parts: an external bolster or bumper that sits against the abdominal wall, a long tube shaft, and an internal bumper that sits against the stomach wall, and a feeding port with a cap. Now, some PICC tubes have a balloon instead of an internal bumper. The key is that the tube creates a stable track between the stomach and skin. Gastrostomy tubes can be placed endoscopically, like as we said earlier, surgically, or by interventional radiology. As we said, the term PICC tube specifically refers to tubes placed by the endoscopic techniques, but commonly used or referred for all. Modern feeding systems include gravity bags, bump control systems, and bolus syringes. Bump control feeding is preferred for continuous feeds as it provides consistent delivery rates and reduced aspiration risk compared to gravity feeding or bolus feeding. Now, once the tube is placed, we must confirm proper positioning before using them. For NG tube, the gold standard is a chest X-ray showing the tube tips in the stomach below the diaphragm bisecting the carina. Bedside methods like pH testing and air insufflations are supplementary but should never replace X-ray confirmation for initial placement. So do not ever use NG tube before confirmation with an X-ray. Look at this X-ray. You can see the NG tube coursing down the esophagus with the tip clearly in the gastric body. In this X-ray, the NG tube tip is cold in the esophagus and has not entered the stomach. This needs repositioning. And here is a dangerous complication: the NG tube been inadvertently placed into the right mediastinum bronchus. Never feed through a tube without X-ray confirmation. Now, for PICC tubes, we typically start using them within few hours of insertion. In practice, we must get the okay from the physicians who perform the procedure before using it. We must also inspect the site for proper positioning of the external bumper. It should sit flush against the skin but not too tight, as excessive tension causes pressure necrosis, while too much slack allows leakage. In this image, you see a healthy PICC tube site with appropriate positioning. This image, on the other hand, shows buried bumper syndrome, where the internal bumper has migrated into the gastric wall, causing pain and feeding intolerance. Now, what are the daily bedside checks when rounding on patients with feeding tubes? First, we must take steps to minimize aspiration risk. Both NG tube and PICC tubes carry aspiration risks, though PICC tubes generally have a lower risk of aspiration and aspiration pneumonia. We must maintain the head of bed elevation at 30 to 45 degrees during and after feeding and avoid supine position whenever possible. Pump-assisted continuous feeding is preferred over gravity or bolus feed. In high-risk patients such as those with previous aspiration or gastroparesis, post-pyloric or jejunal placement should be considered. Also, make sure to inspect the insertion site of the NG tube. Check the nearest for pressure ulcers and ensure the tube is secured properly at the correct depth marking. For PICC tube, assist for redness, drainage, odor, or signs of infection. The site should be clean and dry. Also assess the pain or discomfort at the site. Next, evaluate the patient's tolerance. Is there any nausea, vomiting, abdominal distension, or diarrhea? These suggest feeding intolerance. Nurses routinely assess tube patency by gently flushing with water. Tubes should be flushed with 30 cc of water before and after each feeding or medication administration. If resistance is met, the tube may be clogged, and we'll talk about that soon. Routine residual checks in continuous feeds are no longer recommended except in select cases like high risk for intolerance or if it's still part of your ICU protocol. They do not reliably predict aspiration risk and may lead to unnecessary interruptions in feeding. If it's being checked, high residuals over 100 ml may indicate feeding intolerance. I prefer here also to focus on clinical signs of intolerance such as nausea, vomiting, or abdominal distension or discomfort instead. I will discuss this again soon. And this brings me now to tube maintenance and troubleshooting. Common complications in NG tubes or PICC tube require prompt recognition and management. First, let's start with the clogged NG tubes. These are frequently encountered issue, and prevention is key here. As we said, flush with water regularly, crush medications, and never mix medications together. If clogging occurs, try more water flushes first. Pancreatic enzymes mixed with sodium bicarbonate can be used for stubborn clogs, but never use force to declog the tube, as this can rupture the tube itself. Tube migration or dislodgments needs immediate attention. For NG tube, if the NG tube is pulled out partially, never advance it blindly. Remove it completely and replace it with a new one and confirm with an X-ray. For PICC tubes, if the tube falls out within the first 4 weeks before the tract matures, this is an emergency requiring immediate replacement, ideally within hours, as the tract closes rapidly here. After the first 4 weeks, the tube can be replaced at the bedside with a Foley catheter temporarily until a new PICC tube is placed. So remember the 4 weeks. If you decided to check residual volume in continuous feed and was greater than 500 cc whole tube feeds for 2 hours, then reassess. If residual volume remain above 500 ml but the patient has no signs of tolerance, no nausea, vomiting, or abdominal distension, resume tube feeds at a reduced rate and start a prokinetic, metoclopramide 10 mg IV or erythromycin 250 mg IV, rather than holding the tube feed for another 2 hours. If signs of tolerance present, then continue holding tube for 2 or 4 hours, give prokinetic agent, and reassess again in 2 to 4 hours. Remember that metoclopramide and erythromycin can be given every 6 hours as needed, and remember that both can prolong QTC, so make sure to check EKG and monitor eye telemetry. If intolerance persists despite prokinetics, switch to post-pyloric feeding. Reinsert a new tube feeds, reposition the tube to a post-pyloric position. PICC site infections can happen, like mild cellulitis around the site, and this usually responds quickly to oral antibiotics and local care. Now, severe infection, abscesses formation, or necrotizing fasciitis, of course, requires IV antibiotic and immediate surgical consultation. Buried bumper syndrome present with feeding intolerance, pain, and difficulty flushing the tube. Again, this requires endoscopic or surgical intervention to reposition or replace the tube. In the end, if you like this video, I'm pretty sure you will like my previous video on chest tubes. The link to this video or to that video is provided below in the description field. If you would like again to receive a summary of this video, kindly subscribe to my Substack newsletter. The link is provided below. Thanks for watching and see you soon.